Hello, listeners. Welcome to the Otolaryngology Clinics podcast series. I'm Stacy Eastman, the managing editor for the series here at Elsevier. Otolaryngology Clinics is a bi-monthly publication consisting of review articles focused on a central topic. Today, we have a treat for you and will be featuring a special podcast dedicated to otolaryngology and COVID-19, Where We Are Now. We will revisit topics from the December 2020 special article series dedicated to otolaryngology and COVID-19. Edited by Dr. Zara Patel. Dr. Patel is joined by Dr. Konstantina Stankovic.
Hello, I'm Dr. Sujana Chandrasekhar. I'm the consulting editor for Otolaryngology Clinics of North America. As many of you know, we've been producing podcasts per issue of Clinics for the past several years, and a podcast for each of the recent special sections of the Clinics, which include the first special section on COVID-19, which was guest edited by Dr. Zara Patel and published in the December 2020 issue, and the second special section on intentionally shaping the future of otolaryngology, guest edited by Dr. Jennifer Vilwalk and published over a series of issues from August 2020 to August 2021. You can find all our issues and podcasts at www.oto.theclinics.com. And of course, you can find all our podcasts anywhere you get your podcasts. Today, we have a special treat. This is a podcast for Otolaryngology Clinics of North America that is not based on one of our published issues, but features a topic that's very important and due for a detailed update. I have the distinct pleasure of speaking with two experts in both otolaryngology and otolaryngology manifestations of COVID-19. Both hail from Stanford University in Northern California. Dr. Zara Patel is professor of otolaryngology and director of endoscopic skull-base surgery at Stanford. Dr. Konstantina Stankovic is chair of otolaryngology head and neck surgery and the Bertarelli Foundation professor at Stanford University Medical School. Welcome to both of you.
Thank you for having us.
It's a pleasure to be with you.
I am really glad we're doing this, and I'm so grateful to both of you for taking time out of your busy lives to educate our listeners in this manner. So I'm going to do a quick synopsis for somebody who might have been sleeping for the past 2.5 years. COVID, or coronavirus disease, 2019, so COVID-19, was first identified and named in December of 2019 and threw the entire world into a pandemic by early 2020. As of October 2022, which is when we're making this recording, there have been 620 million reported cases of COVID-19 and 6.55 million deaths worldwide attributed to COVID-19. In the US alone, there have been over 96 million reported cases and over 1 million deaths from this disease. We know that there's underreporting now because there's home testing, and the first and second and possibly third waves of really terrible disease seem to have finished. Long COVID affects 19%, or nearly 1/5 of adults in the United States who have had COVID-19, according to the United States Center for Disease Control and Prevention. Symptoms include brain fog, fatigue, exertional malaise, changes in taste and smell, hearing loss, tinnitus, and dizziness, and they are part of that constellation of symptoms described for long COVID. For today's podcast, I invited these two experts to explain what the research shows about some of the more common questions our patients and their families are asking otolaryngologists about COVID-19. So first, let's start with Dr. Stankovic. Tina, can COVID cause hearing loss? Can COVID cause tinnitus? Can COVID cause dizziness? And if so, how? What's the underlying mechanism?
Thank you for this question, Sujana. Yes, COVID can cause these symptoms. During the first peak of the pandemic, it was unclear whether hearing loss, tinnitus, and dizziness that we were seeing in our patients were causally related to SARS-CoV-2 infection or coincidental because these symptoms are so common in the general population. The underlying mechanisms are not precisely known because we cannot biopsy the human inner ear today since the organ is very small, it's delicate, and it's encased in bone. And for the same reasons, we cannot see cells in a living human inner ear today because the clinical imaging tools that we have at our disposal, which are MRI and CT scans, do not have the necessary resolution. So we studied human inner ear tissues that we obtained during indicated surgeries and discovered that specific cells of the inner ear have molecules that are required for viral entry. And we confirmed this finding using inner ear cells that we made from patient stem cells, which were induced from their skin. So one possible mechanism is direct viral infection of inner ear cells. And the virus could get to the inner ear via the eustachian tube and round window, which is a non-bony opening into the inner ear, or it could get to the inner ear via tiny bony openings in the roof of the nose, which allows seeding of the intracranial space. And yet another possibility is via blood.
So it is rare for viruses to cause the kind of damage that we're hearing about. Back in the old days of HIV, I had the fortune of doing the first set of temporal bone histopathology studies in patients with severe AIDS disease. And we actually found viral particles in the endolymph, which was extremely unusual finding back then. Do we have that kind of histopathological information now, or don't we?
We don't have it yet, and it's an excellent next step. What we do have evidence for is that from human temporal bones, the virus has been isolated from the middle ear mucosa and from the mastoid, but nobody has had the privilege to look at the inner ears from the affected individuals.
You know, I have to say, and I'm dating myself, this was back in the late 80s that we did these studies, and I actually did them with my dad, which was really interesting. But the amount of precautions we took because of the fear of contracting HIV from actually getting these specimens was pretty significant. And I think that is part of why I'm so impressed with the kind of work that both you, Dr. Stankovic, and you, Dr. Patel, have been able to do along with your colleagues to help us understand. So what is the incidence of hearing loss, tinnitus, dizziness in patients who get COVID-19 disease?
Those epidemiologic studies yet remain to be conducted. One of the problems is that these symptoms may be underreported. In general, we are supposed to report to various regulatory agencies, including FDA. And yet, when people are being bothered by what is considered a much more disabling symptom at the time, such as brain fog or chronic fatigue, or even the inflammation of the heart, then they ignore their tinnitus or hearing loss or dizziness to begin with. So right now, these symptoms tend to be rare, which is good. However, I say that with a grain of salt because we really need more data and more consistent reporting.
And then, you know, we've all seen the patients who come in and tell us that their bank teller's cousin's wife got tinnitus and hearing loss after getting the vaccine. And that could have been 1 second after getting the vaccine, 2 weeks after getting the vaccine, or maybe 2 months later. So can you tell us, do these vaccines cause or give you a higher risk for having sudden hearing loss, tinnitus, or dizziness? And what is the time frame that we as physicians should be able to say, yeah, this is likely causative or this is likely not causative?
It turns out that the European equivalent of FDA, which is called the European Medicines Agency, recognizes tinnitus as a potential side effect of Janssen-J&J COVID vaccine, and they actually recognized that last year. The same agency recently recognized tinnitus with AstraZeneca's COVID-19 vaccine as well. Again, we run into the issue of potential underreporting. And when it comes to hearing loss, most studies have found that COVID-19 vaccination does not significantly increase the risk of sudden sensorineural hearing loss. However, there was a study which showed an increased risk, and the effect size was pretty small. So overall, at this point, we believe that the benefits of COVID-19 vaccination outweigh its risk for causing sudden sensorineural hearing loss, tinnitus, or dizziness, and therefore we strongly recommend vaccination.
So let's say you get the vaccine or you get the disease and you get sudden hearing loss, sudden sensorineural hearing loss, tinnitus, or dizziness, or some combination. Is that it? Do we do nothing about it? Or what are the treatments that you recommend?
There are treatments, and we treat these types of audiovestibular symptoms the same way that we treat sudden idiopathic sensorineural hearing loss. And what that means is that the gold standard is topical or oral corticosteroids, and they can be combined with hyperbaric oxygen therapy.
And I believe that in one of the presentations I heard by you, you said that the recovery rate was pretty good if it was treated in a timely fashion.
That is correct. And in general, the sooner patients are given this treatment, the better, because the more likely they are to recover and possibly even fully. So the golden window is within 2 weeks of the onset of symptoms.
And something that we learned, Tina, as otologists during the pandemic lockdowns was the actual usability and validity of smartphone-based hearing tests, that our patients could take their own hearing test in a quiet room, and we could have a pretty nice sense of whether they actually had a hearing loss or not. Just to finish this, the ear part of this, lessons learned from COVID, is that something that you've taken away from these rather difficult over 2.5 years? And is there anything else that you'd like our audience of otolaryngologists from around the world to know about ear care in the time of the pandemic?
Absolutely. We have indeed found that these apps that are available on smartphones can be incredibly helpful. And indeed, we relied on them heavily at the first stages of the pandemic, when audiologists were really concerned about coming in and performing testing on patients who were suspected of having COVID. In terms of what to know about the ear, is right now, the ear doesn't really spontaneously regenerate, especially the hearing part of the human inner ear. The balance part actually does have some spontaneous ability to regenerate. And we think that maybe the reason that we have seen in people who have COVID or COVID vaccine related dizziness, they do tend to get better over time, possibly even more frequently than those with sensorineural hearing loss or tinnitus. And another thing that I'd like to make everyone aware is that we are conducting a study where we're recruiting people with COVID or COVID vaccine related hearing loss, tinnitus, or dizziness. And if these symptoms have occurred within the last 6 months, we are really eager to recruit patients and collect their blood, because we are interested in identifying possible molecular biomarkers that could serve as therapeutic targets going forward.
I appreciate you telling us that. I think the more we know, the more we will know. Certainly, this won't be the last virus to affect our world. I'm interested in the dialogue changing from how do we protect ourselves in the operating room from aerosolized particles, et cetera, while we're drilling, to how do we identify and treat patients early so that they don't develop these potential long-term complications of this disease.
Absolutely. I completely agree with you, and we look forward to doing that important work going forward.
Thank you so much. I really appreciate it. Let's move now from the ear over to the nose. So the nose, the anterior skull base, Dr. Stankovic already mentioned that one of the ways the virus can get in intracranially is through the openings at the cribriform plate at the roof of the nose where the olfactory nerves come in. Dr. Zara Patel has actually been doing research on olfaction for years. This was one of her areas of expertise. And then COVID came along, and the interest in anosmia and hyposmia really ramped up as this was known to be a hallmark symptom of at least the first and possibly, I think, the third wave of the COVID-19 pandemic. I was really interested to see that one of your past fellows, Dr. Carol Yan, who is now at University of California in San Diego, first published on her observations of smell loss in COVID-19 patients in the International Forum of Allergy and Rhinology on April 12th, 2020. And I think back to what we were doing April 12th, 2020, and we were struggling to find masks and gloves and eye protection and, figuring out how to get patients seen without exposing them to the emergency room, etc. But back then, Dr. Yan compared two large cohorts of patients with influenza-like symptoms, one being COVID positive and the other being COVID negative. And she found that 70% of patients with COVID-19 had smell and taste loss, while only 17% of those who did not have COVID had those symptoms. So you, Zara, have really talked extensively about the importance of international communication and really expediting information sharing without limitation of country boundaries. And I think that's one of the big lessons I learned from you during the pandemic. Always, but certainly during this pandemic, when we were able to communicate with each other, audiovisual, and not having to fly somewhere. So Zara, what do we now know about how COVID-19 causes smell loss and distortion?
I'm glad that you brought up Carol's first work, because as you noted, it was right at the beginning when we were just starting to learn about how this was related to the disease process. We learned so much from our international colleagues in Italy and Iran who are sending us information. Now that we have had all this time to actually study the underlying mechanisms, we know a lot more about why this is and how it comes about. So similarly to what Tino is saying about the ear, there are probably multiple pathways, but the main pathway is that we know that the neurons themselves, the olfactory nerves, do not actually have the ACE2 receptor, that receptor that allows the SARS-CoV-2 virus to attach to cells and enter into them. But the supporting cells in the olfactory epithelium, called the sustentacular cells, they do. And so the main mechanism by which the viral particles can enter into the olfactory epithelium is through these supporting cells. They then cause a huge inflammatory reaction, and many of these supporting cells are damaged and destroyed. Now, the great thing about the olfactory system overall is that it is really unique in all the other cranial nerves, and that it does have a very robust regenerative process that occurs many, many times throughout our lifetime. And that's probably, the underlying mechanism by which, when people suffer from, loss of smell and taste associated with COVID-19, the vast majority of them, 70 to 75% of them, will spontaneously resolve that symptom. They'll be able to regain their normal ability. But unfortunately, that leaves, 20 to 25% of patients who don't. And that's when these supporting cells either are not able to bounce back, or during the natural regenerative process of when these nerves are supposed to die off and become replaced by new neurons, the way in which the supporting cells are supposed to help that process along is damaged. And so either new neurons do not come in to replace the ones that are lost, or there's not the correct signal to help those neurons go and make the right connections. And that is likely why we see a higher proportion of patients with COVID-related smell loss eventually develop parosmia or phantasmia, meaning distortion or phantom smells, which can even be more debilitating than the loss itself. So that's the main mechanism. I will say that, just as Tina talks about in the ear, there are probably other ways that the virus can actually enter the brain itself. So through the blood-brain barrier, we know that on endothelial cells, there are these TMPP receptors, and that may be one of the main mechanisms of entry through into the brain, where we know that viral particles can actually get into the brain itself and can affect the olfactory cortex just like the rest of the brain, and may be the reason why people end up having these very long-term COVID symptoms like brain fog and smell loss and distortion of smell and things like that.
So I find that really interesting that it's the supporting cells and the damage to the supporting cells, which is wonderful because supporting cells recover, right? Olfactory neurons tend not to. Is that the difference between smell loss from COVID or SARS-CoV-2 as the virus versus smell loss from, let's say, zinc?
Yeah, so zinc, for example, intranasal application of zinc definitely causes damage throughout the olfactory epithelium to all of the cells involved. So supporting cells and neurons alike become damaged. And unfortunately, that's a sort of irreversible damage. We currently don't have any way of bringing people's smell back if they've unfortunately sprayed something like that into their nose, which, hopefully all of our listeners who are mainly clinicians know that, but many of our patients are so desperate to find things to help bring back their smell. They are really willing to try anything that they read about online or hear from their friends. And as we know, not everything that's sold over the counter is regulated. And so there is the danger of people putting things in their noses that can really harm them irreparably.
So I think, again, similar to what we talked about with Tina, I think educating patients is really, a significant portion of winning the battle with them. I'm not for them, but with them. So somebody comes in, they've lost their sense of smell, they've had COVID. You tell them, oh, you have about a 75% chance that this is just going to come back. So in the acute phase, what do you ask them to do? And then I'm going to just ask you to follow up with yourself. And now the person comes back and it's 2 or 3 months later, their smell hasn't come back. They're really not even eating because nothing smells or tastes like anything. Now, what do you tell them to do?
Just as Tina mentioned with otologic symptoms, the same holds true for olfactory symptoms, in that the sooner you intervene with some sort of definitive intervention, the more likely we are to be able to bring smell back. And so I actually throw the whole boat at them right away. I do everything that I possibly can as soon as possible because, I would love it if everyone showed up a week after they lost their smell, but that's almost never the case. People never get in that quickly. And so, as soon as someone comes in to see you, the very first and most simple thing to suggest that they start doing is something called olfactory training, which, again, when I was talking about this 10 years ago, most people listening or in a room in an audience had no idea what that is. Thankfully now, I think a lot more otolaryngologists know what that is. And it's basically a simple structured smelling protocol where you start with 4 odors. The 4 that we start with are rose, lemon, eucalyptus, and clove, because they are in different categories of odorants. So they'll stimulate different types of olfactory receptor neurons inside your nose. And you just have people hold it below their nose, smell in and out, no special way of breathing or sniffing. But what is important is that they focus their memory on what that is supposed to smell like to them. And it's like rehab. It's like sort of exercise for the olfactory nerves and olfactory system to try to pick up on those odorants and send the correct signal back to the olfactory cortex. And I tell my patients that it does take a really long time to regenerate nerve, especially all those millions of different nerves in the olfactory epithelium. And so I have people do this for 6 months. I prime them for that at the very beginning because it can be really frustrating to do this over and over and not be able to smell. But definitely, I've had many patients tell me that it is only towards the end of that entire duration that they start to really feel like it's helping them, and they're starting to pick up on more odors in their environment.
Do they use oils that smell like this? Do they just go to a rose garden and start plucking roses? Do they go to my Indian spices cabinet and steal all my cloves? Like, how do they do this?
Yeah, so you could smell anything that has a scent, but I would say the easiest way of doing it is with essential oils, just because they retain a smell for a really long time and they're easy to just have there sitting on your sink in the morning or in your kitchen in the morning, and you don't have to keep replenishing them with fresh spices to get that same smell. And so that's why I tell people about it. And some people will think, as soon as you kind of mention essential oils, they'll think, oh, this is just like aromatherapy. This is just supposed to make me feel better. And so that's why I really make a distinction that this isn't just, trying to make you feel better. It is actually training. That's why I call it olfactory training instead of olfactory therapy, which some people will call it smell therapy, because it really is doing something. And we have, some really interesting data that others have done in Europe using functional MRI evidence to show that you can actually take someone before you do training and then someone who has done it for a long period of time, and you can really create that lighting up specifically in the olfactory cortex after doing olfactory training, which is not there before. And so we really are creating new connections and making new areas of the brain work again by doing this.
And again, it's rose, lemon, eucalyptus, and clove. It's so easy as a clinician to sort of memorize those four, right?
Yes. So those are the four we start with. We know that adding in other odors, increasing the number, and then switching up odors at like 1 month and 3 months, that actually increases the efficacy of this exercise. And so if anyone is interested in a handout, I actually did a little patient education page for JAMA that you can just Google and search because it's public access. And so they could just hand that to their patient, and it tells them the first 4 to use, and then it goes into at 1 to 3 months, and then gives some examples of other odors that they could switch in. Really, the important thing is to have a variety of odors so that people aren't training only with all floral or all fruity or something like that. So you're stimulating different types of neurons in your nose as you go through. So that is one of the things that we tell people to do. And again, that's based off of research that I and others have done for prior to the pandemic, post-viral loss. And another study that I had done was also adding in topical steroid irrigation. Again, similar to the otologic discussion we just had, we know that steroids are potent anti-inflammatory medications. Unfortunately, when you're talking about taking steroids by mouth, when you look at the data that we have, again, before the pandemic and even in the pandemic, people are taking oral steroids that doesn't seem to have much of an impact on this. But topical steroids, not topical steroid sprays, because sprays are not going to reach the olfactory cleft in your nose, but topical steroid irrigations, so budesonide in a saline rinse bottle, that actually, with a randomized controlled trial that I ran before the pandemic, did show that it improved the efficacy compared to olfactory training alone. And you'll see in all my studies, I always want to compare against the things that we already know help. So I'm never going to run a study that's just against nothing because I already know that olfactory training can help people. And now when I run studies, I run it against people who have already failed olfactory training and steroid irrigations, because I want to continually improve on what we already have, not just kind of say, oh, this would also work just as well kind of thing. And so those are the two things that I really start everyone on. Now, there's something else based on a study I had ran in a different patient population, people who had had skull-base surgery, who we knew were not recovering their smell very well after that surgery, even when we took great care to protect the olfactory epithelium during the surgery. And I wanted to know what we could use to help those people. This was like 7 or 8 years ago now. So I chose high dose omega-3 to trial in that patient population based on a lot of interesting data that was coming out in the neurologic literature at that time. And that showed a precipitous drop in the number of patients who had long-term problems with their smell compared to just, doing saline rinsing alone, the normal protocol after skull-base surgery. And so that is something that would be an extrapolation to this patient population, but certainly, it has a very low risk or side effect profile. The only people that I do not have use this are people who have underlying bleeding disorders or are on blood thinning medications because it can thin your blood a bit. But other than that, everyone can do well with this. And then there's just one final thing that I've just found from a randomized control trial, specifically in COVID-related smell loss, which is using PRP. So that's platelet-rich plasma. And again, this is something that I became interested in before the pandemic because of, literature and other medical specialties. It's used for a whole host of different things and other specialties, but it's basically taking someone's own blood, spinning it down in a specific centrifuge in a very specific way, and you get this platelet-rich portion of the plasma, which is also rich in growth factors, which all the tissue in your body uses to regenerate. And I've just completed that randomized control trial, and we just presented this at the recent American Rhinologic Society meeting, and we have submitted this for publication, but it is not quite published yet. But basically, it was a successful trial. And similarly to all these other things that I've just described, it's not some dramatic, crazy effect where someone can't smell one day and then the next day they smell perfectly. This is a moderate but clinically significant and statistically significant effect that can improve their smell compared to placebo, which was just injecting saline. So that's an additional thing that now I'm opening it up to all my patients with smell loss as a potential option.
Is that an intravenous delivery or intranasal delivery?
It's an into the olfactory cleft directly that I'm injecting the PRP submucosally.
So it's an office procedure for you?
Correct. Yes, exactly. So you just, numb the patient up really well. You give them first a little topical spray, and then I put that same medication on some cotton pledgets and gently place that within the olfactory cleft. And then once they're all nice and numbed up, they tolerate the injection really well.
And when do you start to see benefit? And as you said, we don't have the magic pill that everybody thinks we're hiding in our back pocket, but this sounds really very promising.
The study itself, the way it was designed, was to have 3 injections separated by 2 weeks each. And when we saw the significant difference was after that 3rd injection. And so, I would say this is so new, and that was just the protocol that I chose. In my pilot study that I had run before the pandemic, I just injected once. And, that was a very small number of patients. It was like 7 patients that I trialed this in beforehand, just a pilot study to make sure that it was feasible, that people would tolerate me injecting into their olfactory cleft, that it was safe. I wasn't going to make them worse or grow any tumors or anything like that. And so I proved all that with that small number of patients. And of course, without a placebo arm and with that small number, you would not be able to conclude anything about efficacy. But I did see an interesting enough shift in threshold, even in that small group of patients, that's what prompted me to run this randomized controlled trial with it. And so, I don't think we really have it figured out yet. What is the perfect protocol? How many injections is the number that will be the best to help people with this? At this point in time, when patients are interested, I basically just tell them about the protocol of the study, and then they can choose whether they want just one or they want all 3. And then I think I will have to think a little bit about if people want more than that, whether it's worthwhile or whether we need to do more study first.
That's really wonderful. I mean, it was hard enough just to be a doctor during this time. And, you doing all of this, I've been impressed by you for years and years, and I remain impressed by you. Like we talked about with Tina, it's very interesting to me that the first time you and I had this conversation, we were talking about, again, draping the microscope, protecting ourselves, protecting the team from aerosolized particles. In the office, a lot of people stopped spraying decongestant and anesthetic sprays before fiber optic scopes, basically during 2021.
Yeah.
What do you think about that? Do you think that there is some risk? Do you think we can just go back to where we were during 2020 and 2021?
Right.
People stopped.
So I think that, we've learned a lot about not just the types of procedures and things that create aerosolization in our clinics, but also in general about, what creates the aerosolized particles. So, people just speaking, talking, laughing, those things create aerosolized particles also. Once we realized that, it became obvious that perhaps all these measures are kind of a moot point. The way in which, to protect yourself, the fellow providers that are with you, whether they're APPs or residents or students or nurses, and also other patients that will enter the room after that patient, is not really to change much about the way in which you are delivering your care, but to perhaps improve the flow of air in that room. So, for example, at Stanford, we have HEPA filters installed now in all of our rooms. And so we know that the turnover of airflow in that room is very rapid. And so we're not worried about, any next patient that comes into the room. We have standardized cleaning protocols between each patient that clean everything appropriately. I think those are the types of things that really will keep moving forward. But we use topical spray now, and it was only a very short time period where we were not doing that while we were learning about all these things. But at this point, you are not exposing yourself to any increased risk spraying anesthetic into someone's nose compared to just actually, doing the scope itself, having them talking to you while their mask is down during an exam, things like that. And so overall, we've learned a lot since the beginning. We've spoken a bit about, the ear and the nose, and perhaps after covering these two cranial nerves so far, of the cochleovestibular nerve and the olfactory nerve, we are also finding a significant number of patients with COVID-19 and especially long COVID manifesting vagal nerve issues. So, Sujana, what do ENTs need to know about post-COVID vagal nerve neuropathy?
Thank you for turning the tables on me, Zara. As you know, my specialty is otology, but I happen to work with a really accomplished laryngologist in my office. And we were noticing that many of these long COVID patients had vagal nerve dysfunction. There was a study done in Spain looking at about 348 patients with long COVID, and at least 2/3 had at least one symptom that suggested vagal nerve dysfunction. And when they looked at a smaller group in detail, 45% had swallowing problems and 45% had voice problems. And then half of the patients had these flattened diaphragmatic curves and trouble breathing. And there were some voice changes that were just audible in a third of them. So Jonathan Aviv, who I have the pleasure of working with in my office in Manhattan, Byron Thomas Shaw, who's a pulmonologist at Columbia, and I identified some patients with long COVID who were having shortness of breath, not at rest or during sleep, but with vocal exertion, like talking, shouting, singing, and even some exposure to some odors. And we looked at a cohort of about 18 of them who had repeated full pulmonary workups, chest CTs, all sorts of pulmonary examinations, with the only abnormality that was found was a flattened inspiratory curve on spirometry. And we did not find vocal fold paresis. There have been a few case reports of vocal fold paresis after COVID. Here in these patients, we actually found paradoxical vocal fold movement disorder, which has been described in other post-viral conditions. So similar to your research, looking at things before COVID, there were in fact viruses before COVID, before SARS-CoV-2. And what we found with these patients is that they couldn't really get a 3-sentence paragraph out without losing their voice. So a Zoom presentation or a teleconference was really tough for them. And what we would see when we examined their larynx in the office was that they were closing about 50% of their airway during quiet inspiration instead of having a nice full opening. This was not due to a paretic cord, but a paradoxical movement of the vocal cords. And so the test was, while we were examining their larynx, to have them say the 5-word sentence, "We see 3 green trees." And in these patients, they could get those words out. And then we'd see that the vocal folds didn't snap shut, but would slowly close. And in one instance, up to 9 seconds before they could breathe again. So once Dr. Aviv made this diagnosis, because of course I did not make this diagnosis, I had a clue that something was wrong with them. And I'm like, please go see somebody who is far smarter than I am. But once Aviv made this diagnosis, then they could be treated actually with vocal physical therapy, which is respiratory retraining, and dietary modification. So avoiding foods with a pH of less than 4 is actually really key for these individuals. So that includes flavored sodas, bottled iced tea, citrus, tomato sauce. Raw tomatoes are just fine, but tomato sauce is very low in pH, vinegar, and wine. And you have a lot of people taking like rice wine vinegar or some other vinegar. I don't know. They're all drinking vinegar. I don't know why people are drinking vinegar. These people were really, really sidelined by this long COVID symptom. So I think, in COVID, we're seeing these smaller little cohorts that are providing us information to move forward.
Yeah, I think that's so interesting to hear, especially because I actually did have a vocal cord paresis after I had COVID. And I know that you guys
Wow.
didn't find that, but I also still have shortness of breath, even though I think that, like my voice is actually kind of back to normal. And so I haven't had a scope since the very beginning. But that's so interesting to hear that exercise and then to see the vocal cords close paradoxically. I wonder if that could actually explain a lot of the long-term shortness of breath that people experience. We have a long haul COVID clinic, like a post-acute COVID syndrome clinic is what it's called here at Stanford, like many major medical centers do. And one of the sort of frustrating things for patients who have breathing difficulties or feeling shortness of breath is that all of their normal testing is pretty normal looking. And so there's not a really good answer and therefore not really great treatment options thus far for them to get those types of symptoms under control. And so I wonder if this may be a key to working with our pulmonary colleagues and figuring out how we can improve that type of symptom.
I love this because I think this is the cross-pollination you've talked about across countries, and we've, talked about across disciplines. And it's really, if you ask somebody, when does it really bother you? People with lung problems have trouble, when they're sleeping. They have trouble when they're exercising. These people have trouble sitting at a desk as I'm doing and just talking.
Yeah.
Right. And that's a very different problem. And I like the "we see 3 green trees." And then you just watch them and see what happens.
I'm afraid to say it.
Don't say it. Don't say it. I'm not there. I'm not there to force your vocal cords open again. So, but thank you. Thank you for allowing me to share that information, because, the purpose of us putting this podcast together was really to, one, thank you so much for adding this to your first work back in 2020 to really help otolaryngologists around the world with your special section on COVID, and then with that podcast. But then to come back, we were in a different, more frenetic period of time back then, really hoping we'd all just survive and make it. I remember the first night of sleep I got really in 2020 was on December 11th, when the first COVID vaccine was approved in the United States, and I could finally see the light at the end of the tunnel. So we've talked about what we should do in terms of scoping people in the office and in terms of HEPA filtration and environmental measures. President Biden stated on 60 Minutes in mid-September that the pandemic is over. And 46% of people in the United States have returned to their pre-pandemic lives. And I think that number will be higher or lower depending on geographically where you are. Especially, I'm in New York City. We were really hard hit in the beginning. Unfortunately, just about everyone I know has lost someone to COVID or has had, bad personal outcome. So I think maybe we might be a little bit more cautious up here. But we still have 30,000 people hospitalized with COVID per day in the United States. And we still have 400 people dying from COVID every day in the United States. Anthony Fauci, the outgoing director of the National Institutes of Allergy and Infectious Disease, estimates that it'll take about 10 years for COVID-19 to become endemic as opposed to pandemic. And one of the ways to do this is, of course, by mass vaccination. About 70% of the US population has had full initial vaccination. About a third have received one booster dose. Only less than 2% have actually received the new bivalent booster that seems to be targeted particularly well against the Omicron variants of COVID. So Zara, do we just put down our masks and go about our business? Like, what do we do? What's right?
Well, I wish I knew the answer, but I think it's really interesting to think about, and it's something that we should be thinking about, because as we sort of transition from, as you sort of stated, that frenetic first time period within the pandemic where we didn't know much, and so we were trying to protect ourselves as much as possible because many people were highly and very morbidly affected by the initial strains of this virus. I do think that we should take into consideration the slowly less morbid demonstration that this virus has taken on in later strains. So, for example, we now know that people are certainly still affected and still hospitalized and still dying, unfortunately, even from the Omicron variants. But that is affecting much more the patient population that we would expect many viruses to affect. So, for example, we know that the flu virus, affects elderly and immunocompromised people much greater than everyone else. And that is why at this point, there are some people that the flu vaccine is recommended for elderly, immunocompromised, and then healthcare workers, of course, but not for everybody, because again, it's not something that is going to hospitalize or kill most people in our patient population. And so I do think that we need to take that into account. I think that what is really interesting and could be very helpful for all of us is this new technique of examining the wastewater in particular geographic areas and in particular cities, because that really gives us a lot of information way earlier than the results of testing gives us. So, the ability to look for new variants in the wastewater, we would know way further beforehand, before people come in and start testing once they are sick and they're getting symptomatic. That's such a small percentage now of all the people that get this virus, that just testing the wastewater to see what our next vaccines should even be made up of and what they should vaccinate against. Those are ways that we can kind of perhaps get ahead of a virus like this. And when it comes to masking, as you said, there's going to be different policies in every geographic region based on what that region has experienced and what their overall sentiment is from the pandemic, but also hopefully based on things like wastewater reading, so for example, here around me, I know that there has been no significant new variant in the last month. And so say, for example, I had COVID a month ago, and I know there's no new variant that has come about since that happened. Perhaps it does not make sense for me to get this most recent booster if I've already been exposed to that virus by actually, contracting it myself. If someone is in a geographic region where they had, either they got the vaccine from a while back or they contracted the virus itself from 6 months back, now we know that there are multiple other variants that have in the last 6 months, it would make sense for them to get the booster and protect themselves from those variants that we know are going to be there and affect them eventually. So I think that really fine-tuning the way that we respond to this type of disease state is the best way forward and the best way to be transparent with people so that people don't think that we're just making policies, for no reason.
I think that is possibly or definitely the most thoughtful take on this question because, we are also going into the cold and flu season. We're seeing lots and lots of viruses pop up that had not had a place to rest because people were isolated from each other and masking. We are seeing, just about every person who's taken an international flight has come down with COVID subsequent to that, right? So we are seeing that there is transmission. As you said, we are not seeing, with the exception of, 400 lives a day, which is a huge number, but we are not seeing that rate of really sick people, really deathly ill people. And hopefully we're seeing that as a result of vaccination, those who are getting the disease are getting it a less aggressive version or a less symptomatic version. But I really want to thank you for that. I think that really keeping an open mind, knowing your local area transmission rates, knowing how much risk you're willing to take, right? So a doctor gets COVID or a nurse gets COVID, they can't go to work for at least 5 days. Right. And that's a huge number of patients who don't get seen and don't get cared for. So you have to really think about what's the downstream consequence of getting even a relatively minor case.
And not just that, but for people to consider that, take smell loss, for example, although it is definitely occurring in a much lower rate with these Omicron variants than it was, for example, with the Delta variant, it still is affecting probably approximately 20% of people. And that's still millions of people who, even if they had no other symptom and it didn't affect them in any other way, that is going to be hugely impactful on their quality of life for the rest of their lives, potentially. And so that's another thing to consider when you want to think about the risk that you're willing to take. It's not just, I'm pretty immune competent and therefore, I'm not worried about getting in the hospital. Really, the thing that I think about most is, am I going to be in a place that transmission is high enough and a variant is new enough that I run the risk of losing my smell and taste? Because that, right. I've treated enough patients at this point that I know how honestly terrible that would be if it happened. And so, everyone, like you said, needs to know what they're willing to risk for themselves.
Well, I want to thank you so much. I am Sujana Chandrasekhar. I'm the consulting editor of Otolaryngologic Clinics of North America. And today I've had such a pleasure talking with two women, two professors, two researchers, two clinicians whom I admire to the moon and back. Dr. Konstantina Stankovic, who is the chair of otolaryngology at Stanford University Medical Center in California, and Dr. Zara Patel, who is professor and chief of anterior skull-base surgery at Stanford, particularly knowledgeable in this area and always fun to talk to. Always makes me learn and think in a different way when I talk to each of you. So thank you both for being here today.
Thank you for joining us for this edition of the Otolaryngologic Clinics podcast series. Otolaryngologic Clinics is available for individual print subscription with accompanying online access or individual online-only access, and is also available on the Elsevier electronic platforms Clinical Key and Science Direct. For more information on this series and our nearly 60 other titles spanning all medical disciplines, visit info.theclinics.com. Be sure to follow us on Twitter and subscribe to our podcast wherever you get your podcasts.